Please don't let it do that. You can find it, click a link, and answer 17 seconds of questions to get your CE. All right. Let me introduce these folks. You didn't come here for me anyway, because my face wasn't on the tile you clicked to register for this thing. All right. Ladies first. I'm going to start with Lacey. Lacey Adams, RPSGT CCSH, because we need more acronyms in the world, but that's a long title. If you didn't have an acronym, I get it. Lacey is a sleep coach with Enzo Data. She's a board certified sleep educator. She's certified in clinical sleep health. That's the CCSH behind her name. She's got over 8 years experience as an RPSGT. She specializes in diagnostic sleep testing along with treatment and management of sleep apnea and other sleep disorders, of which there are many, for those of you that don't know that. Lacey started out as a night tech, transitioned to utilize her CCSH skills as a daytime technologist, helping patients with PAP acclimation, compliance, and sleep-related issues. Thank God for people like you, friend. We need more people to help patients with PAP in this world. That's for darn sure. You were a sleep lab director, assisting with building state-of-the-art sleep lab within a wellness center. Today, you are coaching, offering guidance to folks with PAP therapy, and you hail from Alabama with your husband and your 2 precious kiddos, who we will not hear in the background, even though you're central time. Right. All right. Because, when the tree falls in the forest, no one's there to hear it. It doesn't make a sound. So when nobody hears the kids being put to bed, it didn't happen. Shahnawaz Khan, same acronyms, RPSGT, CCSH. You guys have some stuff in common. You have been doing this. You've been in the sleep field for the past decade and a half, 15 years. You began working as a technologist for the University of California, Santa Barbara. Whoop, whoop. During that time, you fell in love with the field, became registered, moved to San Francisco to work as a sleep tech at Stanford Sleep Center. I have questions for you about that. Everybody does, right? This led you to acquire the CCSH, that's the coaching side of that license, and work with the board of RPSGTs, the BRPT, on the examination development committee. Since then, various roles, research, tech institutes, and a dedicated score for over 20 different sleep systems. Thank God for people that have your brain, because I would just want a gun. I'm just going to be honest. Like I was a tech. Everybody, most people on here know this. They know me enough. I was a tech a long time ago. I loved it till I didn't. I love the people, not the squiggly lines, even when they were live tracings. You get it. I learned on banana leaf paper. That's another story. They're not here for me. Guys, listen. Both of these awesome people, audience here, please hear me. Sean and Lacey have exponential experience. They're both registered sleep techs. They've also used that to become sleep coaches in their respective field. They have a ton of technical information to get to you, and we'd love for you to listen. And please, again, if you're answering their questions, use the chat. If you're asking your questions, use the Q&A button. We appreciate you, and I'm going to get out of their way. So, Sean, will you please kick us off and start this thing?
Hi, so we're going to be talking about deciphering sleep tests in dental medicine. And I'm going to actually hand it off to Lacey. She's got a cool story for us.
So I am going to start this off with a story, but first I wanted to add, as a sleep coach, well, the reason I even pursued sleep coaching coming from just the tech world to begin with is because I found myself in this weird place where I actually appreciated and loved the conversations that I had with the grumpy people, the irritable people, the people that were difficult to work with, because knowing in the back of my mind what was going on with their sleep, I had this benefit of the doubt, this like, okay, I'm going to give them grace because they're probably just grumpy because they have really bad sleep. So maybe that's the case, maybe it's not, but you know what it's like. We've all had a bad night's sleep before. Do you remember how you felt that following day? Maybe you were up, like pulled an all-nighter and you were like studying for a big test, and maybe you had to recover the next day. Just last week, So I have two little ones. I have an 18-month-old, and then I have a 5.5-year-old. And my 5.5-year-old came down with strep all at the same time. My 18-month-old was cutting all 4 of his canine teeth, or eye teeth, cuspids, maybe there's a right term. Y'all can answer that for me, because it could be all 3. But he was cutting all of them. So at some point in the middle of the night last week, I ended up maybe being up 3 times, gave some Motrin, ended up with both of them on either side of me, just laying in the bed as my husband sleeping next to me with his CPAP, just snoozing. But my sleep really wasn't good that night. Like, I struggled. So the next day I may have been a little extra irritable, a little more grumpy, a little more foggy headed, just kind of on the struggle bus. I'm sure in telling that story, you guys have come up with your own thoughts. Maybe you're a parent too, and you know exactly what that's like. Or maybe you just have your own struggles. So when I think about people with sleep disorders and sleep apnea specifically, my heart goes out to them, because I think, like, man, is that what they feel like every day? Like, is that their norm? So I've got this big heart for people who struggle with sleep, because I value my sleep so much. So we're going to dive into that a little bit further. Sean, I'm going to share them our little.
Hey, thank you, Lacey. So what is sleep apnea? Instead of just going ahead and telling you, we got something to show you. So here's a minute for you to watch. Wow. So as a tech, and I'm sure just as a person observing that is kind of hard to watch. And if you were observing, just kind of seeing what was going on, that was somebody having obstructive sleep apnea. If you were observing how they were breathing, they were trying their absolute best to be able to get their breath out, but their airway was so obstructed that the muscles were moving and there was no air to come out. And essentially they were choking. And right at that moment, from that first like guttural snore, they were gasping for breath. And even so that one of the most alarming things about this video is that they're propped up by their arm, which is absolutely fantastic. I mean, I'm amazed at that. But even then, they aroused. They woke up briefly to be able to get that oxygen back, because they were definitely losing the flow to their brain. So this is something that I'm sure bed partners complain about their, partners snoring and stuff like that. This is one of those instances that is kind of eye-opening. And I'm going to throw it to Lacey to tell us what's behind the snore.
So we brought a few visuals in here. Obviously, we don't have that man's sleep study, but I wanted to go over this visual with you to kind of go over maybe what it would look like on a sleep study. People often describe obstructive sleep apnea as you stop breathing when you're sleeping. And maybe that's a simple description, but for people to understand that, okay, you're not just stopping breathing, your body is actively working to breathe, but you're just choking. Like, there's obstruction here and your body is working to breathe. So it's not just that you stop breathing, but like your body is fighting to get that breath. And so what you're looking at here is an actual like in-lab sleep study. And so we're going to touch on in-lab polysomnograms versus home sleep studies throughout this. But here you're seeing a visual of a couple of their brain waves. You're seeing some eye movements. You're also seeing just a snore, but you're seeing heart rate. I mean, like an EKG. And you're also seeing leg movements. You're seeing like 4 leads of respiratory. So usually in the in-lab sleep study, you've got 2 where you're monitoring nasal and oral airflow. And then you've got 2 belts where the belts are moving. So, and then in addition, you're monitoring SpO2 levels. So here we're looking at like a 2-minute window, or maybe less. So each of these rectangles that you're looking at are 30 seconds long. And so when you're looking at this specific study, this person is having obstructive apneas and they're lasting like 20 seconds. And I'm just going to pause there for a quick second. And I want to give you a chance to just think about that. If you want to hold your breath with me for 20 seconds, I'm going to count and just go from there. Okay. That gets pretty uncomfortable. Like that's uncomfortable for me. And if you can imagine, this is happening like within this minute and a half, this screen right here. You've got 1, 2, 3, 4 obstructive apneas. It's causing this person's oxygen levels to drop somewhere from 94 down to 76, I believe. Yeah. Some of the heart rate you can't see too much, but there's variation from like 88 to 66. Like there is disruption in this person's sleep. He's holding his breath for this long. Then you've got 1, 2, 3, 4 recovery breaths, and then it happens again. So if you imagine this happening over and over and over and all night long, how this is why sometimes people wake up more exhausted than they even fell asleep to begin with. This person is in stage 2 sleep. And so we'll go into a little bit further. But if somebody is in REM, rapid eye movement, their body goes into this paralysis where everything completely and totally relaxes to keep you from acting out your dreams. But that typically means your sleep's going to get worse, your breathing is going to get worse because there's more collapse. So in this person's case, it could have gone a lot worse.
Thank you, Lacey. So I'll go ahead and discuss a little bit more about some of these respiratory problems, some of the apnea that's happening. In this case, we have a home sleep study, which is a lot less involved. We have a lot less wires, a lot less channels, and we'll definitely be going more in depth, talking about which kind of components, home sleep studies have versus full in-lab sleep studies. But here, as you can see, when you see this kind of wave go up into this kind of hill-like motion, that's the inhalation, and the drop down is that exhalation. So if you see the baseline, it starts to kind of dip more and more, and that constitutes, airway resistance, cessation and flow. And here we have as well as a drop in oxygen saturation from 93 down to 87. And this is per the ASM a hypopnea. So a hypopnea is a cessation of 30% in airflow, accompanied by a desat and or a arousal that typically is seen more in polysomnograms. So in this case, one of the ways for us to be able to tell is per the desaturation. But as you can see, we have 1, 2, 3, and maybe even a 4th over there. And we're having continuous airway obstruction. And it's one of those things where if you think about having something that needs to be done kind of in motion, in serenity, in continuous movement, but just facing constant interruptions and constant interruption to your brain getting proper blood flow, proper SpO2. So this is an example of kind of what the hypopneas on a consistent basis look like on a home sleep study. Here we have a side-by-side look between a home sleep study and a full PSG. And much like Lacey discussed, you have your EEGs, you have your eye leads. Underneath that, you have EKG. You have your chin movement. The significance of chin movement being that when we enter the state of REM, our muscles go completely atonic. So you're going to see a complete flattening in that muscle tone. So that's one of the factors that we use to be able to determine whether or not a patient is in REM, amongst other factors as well. You have the PPG which is the plethysmography, which is basically the flow of the infrared that goes through the SpO2, showing how much of the white blood cells activate and how much, you're basically having a cessation of. So if you notice, it seems uniform and then it starts to go real small and squiggly. And that if you look all the way down, you can see that there's also a 16% DSET, which is significant. As well as we have our leg leads, snore indicators, nasal, thermistor, thoracic, abdominal. And also, which is very important, is a positional sensor that lets us know what position the patient is sleeping on. And the snore. So one of the important things about understanding about snoring is that snoring is indicative of a partially obstructed airway. And if you look in the back of your mouth, you'll see the little teardrop, which is the uvula. And whenever that starts to have a bit of resistance and a little bit of occlusion, that causes that vibrational sound that we all know as snoring. Not a great vibrational sound, but a sound nonetheless. And as you can see from the difference between the way that the morphology of the wave is, you can see that as it goes up, it starts to kind of flatten up a little bit, and then it goes back into an exhalation. There's a resistance that's happening while the patient is snoring. And snoring is not always, if you snore, it does not mean that you have sleep apnea immediately. However, it is a very high indicator that you might have sleep apnea. So it is a telltale sign that if you're snoring, you might probably have sleep apnea. So it's worth looking into at least. And I will throw it to you, Lacey, to talk about this awesome infographic.
So I really like this infographic because it gives you this complete visual of how sleep apnea can truly, if it's untreated, affect somebody from head to toe, like from memory problems to risk of stroke and risk of heart issues, intimacy issues, all the way through hormonal problems. Like there's such this vast array of issues people run into. And I'm sure looking at this as dental professionals, I know that there's a lot of periodontal issues that are related to some of these things, like kidney problems, like diabetes. Like there's just this variety of somebody's whole entire wellness being so important, just as y'all know, in your oral health, but your sleep health being so foundational. I like this infographic because it lists everything from the lack of oxygen causing memory issues, brain fog, goes hand in hand with morning headaches when people wake up. My father recently had open heart surgery. So being a sleep coach and talking about sleep apnea for years and years and years, because he and his doctor never had the conversation and never pushed him to pursue his health, no matter how much I described the snore and how it relates to itself. He never was able to have the conversation with his doctor. And so part of why I want to bring this forward, and something you can think about as we move through this slide, the importance of bringing this conversation into dental visits as well, because maybe somebody will never have the conversation with their physician, but maybe they'll talk to you about it. And the fact that it's just so detrimental to our health when we don't treat it, it's just important to bring up the conversation. So I'm going to dive a little bit deeper into this diagnosis dilemma, like I call it. I'm sure you've seen statistics like this. Even though people are becoming more and more aware of how important sleep is, whether it's with the wearables we have and just access to the internet, this 80% of people undiagnosed in our country has kind of been a statistic for a while. I've not seen it improve very much. I've actually heard more that it may be closer to 90%. In some of the research that I've done, like pretty much this is showing about 80% of people are undiagnosed and actually have moderate to severe sleep apnea. And so for people who have more mild sleep apnea, that may be an even higher statistic. It's just a lot of people who need help. And so, again, I love the idea of bringing this medical community with the dental community and collaborating to help these people. So moving beyond diagnosis, there is this huge issue with just the outcome struggling. So like, what's the point in giving somebody a sleep apnea diagnosis saying, okay, yeah, here, this is what's going on. Yeah, this is super detrimental to your health, and them not seeing benefit. It's pretty heartbreaking. So my experience mainly is with people adjusting to CPAP therapy. And I love CPAP. I see it work and I see it eliminate the sleep apnea. And so I'm a believer in it. But based on these statistics, I mean, you're seeing people 8 to 15% who refuse CPAP treatment after their first night. At least 50% of individuals discontinue usage within 1 year. And then this statistic, adherence to CPAP, varies from 17% to 71%. With CPAP being the gold standard and people struggling so much with this adherence, I'm looking at statistics here, but just like that video we saw, I can't help but think of like the human behind it. There are people that I've worked with struggling getting started on CPAP, and by the time I got in touch with them, I found out that they're taking care of their wife who is dying of cancer, dealing with hospice coming to the home, and all of that entails that roller coaster of just life. He'd put his health on the back burner. And so finally being able to communicate with him was wonderful, and being able to help him with his health. But there are a lot of people who don't get that option. And so for people who have tried CPAP and failed, or don't think that they could ever even try it, just knowing that there are other options could literally save their life. But you can't try other options if you don't know there's an issue to begin with. So just a mention of a few other treatment options. I know you all know this, the mandibular advancement devices. There are so many different brands. But I love seeing just options that people have, from CPAP to oral appliances, the emergence of Excite OSA and daytime therapies to help with nighttime. INAP is something that I think is super exciting because it's negative pressure, the complete opposite of CPAP, but the whole idea is to still move the tissues away so that this person can breathe, all the way through surgical options. And there's a number of those, but including hypoglossal nerve stimulation like Inspire, and there are several other too. But again, just the conversation to let somebody know, hey, this is what's going on, we can help you. And then we have options for you. We can find something that can be successful. Something is better than nothing. And the whole fear of CPAP is a lot of times why people even run from the sleep test to begin with. So again, I know I mentioned that medical dental collaboration. What excites me about this is just similarly to what I mentioned about my dad's story. I think about there's a demographic of people, and I'm not really sure what statistics look like, but a demographic of people that may not see their doctor every year, but they may come see their dentist at least once a year. And so they may not have the conversation with their medical physician, but to have the opportunity to have that conversation with you is huge. You as dentists and literally looking in people's mouths every day, you are uniquely and perfectly positioned to see what's going on in there. And there may be a lot going on in there. I know we've talked about snoring, but that's not everybody's story sometimes. Sometimes people may grind their teeth at night. So you may see symptoms of bruxism. You may see scalloped edges on their tongue. You may see just the way that their palate is shaped. If they've got this high arched palate, and if they have, in addition to the snoring, you may see some redness and irritation in their throat from snoring or even acid reflux. So this variety of things that, again, they may not say I snore and they may not think anything's wrong, but you see all these telltale signs and you see red flags because you get the chance to look in their mouth, and it just gives you opportunity to create this conversation.
Whoops.
I'll let you go.
We just pressed it at the same time. So we've learned a little bit about sleep apnea and different demographics and different components. Let's talk a little bit about screening patients. So some common sleep complaints, snoring being one of the biggest ones. There's a lot of different things that you can experience when you're having sleep apnea, as well as in some cases not experiencing many of them at all, because of the fact that sometimes you have to think about, if you've been dealing with something for so long, sometimes it becomes a feeling of like a baseline. It feels regular to you. But some of this list consists of things like excessive daytime sleepiness, constantly feeling fatigued, never feeling like you've gotten that proper night of rest, despite, sleeping or being in bed for 8 hours or, more, feeling that level of frustration. Bed partners, saying that they've witnessed apneas, that they've noticed people not breathing at night, choking. They're having to push them to the side, or they're having to pull an I Love Lucy and sleep in a different room, which is a lot more common than you'd imagine with patients who have severe sleep apnea. Sometimes they have a hard time initiating sleep. They are trying their best, but they can't, or they end up waking up in the middle of the night many, many times over. And because of just our behaviors in general, sometimes watching TV, sometimes eating in bed, a lot of different things that can also affect that quality of sleep, because you want to be able to sleep through and through. You want it to be like a nice, smooth night of sleep and not have all these interruptions. Something called nocturia, where people have frequent nighttime urination, which can be definitely influenced by sleep apnea. Brain fog, impaired cognition, not remembering things. It's hard to express, but I myself have sleep apnea. I wear CPAP, so I know the experience of just like not being able to say a word that exists, but there's just something blocking your mental process, and it's very frustrating. And people, the more we become aware of it, the more people become empathetic to understanding how that might, it might happen, as well as having morning headaches where you just can't get out of bed because your head's just pounding and you can't make sense of it. And you just don't know why you feel worse than you did the night before. And this list, sometimes people have everything in this list. Sometimes people have a few things in this list, but this list is not the entirety of what people experience. There's many, many more things that can happen when people are having sleep apnea and sleep related issues. So one of the questionnaires that we typically give out in clinics and they issue out to patients called the Stop Bang. And this questionnaire typically has a yes or no answer. And then it comes up with a certain calculation in which it shows whether or not you are a higher or lower risk for having potential sleep apnea. This is not the only questionnaire that's given. There's other questionnaires that are given, but this is more of a popular one that is often given throughout different sleep labs, etc. Some of the questions consist of: do you feel tired, fatigued, sleepy during the daytime? Has anyone observed you stop breathing or choking or gasping during your sleep? Do you have or are being treated for high blood pressure? Another question asks about your body mass index. Is it more than 35 kilograms? Are you older than 50? Because older people have a higher propensity for having that sleep apnea. Your muscles start to decay. You start to have a lower muscle tissue and all these things. So those are definite factors. The size of your neck. Is it more than 16 inches, 40 centimeters or larger? That's also a factor. If you're a male, you automatically get one point for that, because men have a higher likeliness to have sleep apnea, especially within the size of their neck being larger as well. So these are some factors that are calculated in the stop bank. One of the more popular one that I've seen in every lab that I've ever worked at is the Epworth Sleepiness Scale. And it's a simple list of questions that start from 0 to 3. And we simply ask, as a pre-screening, we'll ask patients these questions. How often do you doze? And by dozing, just falling a little bit asleep still counts. Falling asleep definitely counts. So 0 to 3, how often do you doze? If you're sitting and reading, do you forget the plot of the story all the time because you fall asleep? Watching television, sitting in a public inactive place. If you go to the movie theaters, are you known as that friend who always falls asleep in movies? I definitely have a few. When you're riding in a car as a passenger, do you fall asleep? These are all very common scenarios that I'm sure each and every one of you knows at least one person who would put 3 on one or multiple of these. When you're sitting and talking to someone, in my experience, I've seen that a little bit less. However, that would be very interesting, to talk to someone and observe them fall asleep. Sitting quietly after lunch, big point, without alcohol, and also stopped in traffic for a few minutes, which is a very important one to think about as well, because if you're falling asleep while you're driving, you need to be mindful of what's going on, because you can be a danger to yourself and to others on the road as well. So one of the more visual ways to identify and see whether or not you are a higher risk factor for sleep apnea is called the Mallampati screening. I have no idea why it's called that, but I definitely learned about it. And it's a very interesting way to identify varying levels of airway resistance. And as Lacey mentioned, dentists have a unique opportunity to be able to see and kind of perform this way of observing someone having sleep apnea or having a higher likeliness for it, or being able to see which class of Mallampati the person has, because not often are we going around and showing people, opening our mouths and showing other people. Like, that's something that never happens. It pretty much only happens at the dentist's office. So it's very uniquely, I feel like it's catered very well for dentists to be able to take a quick look and see. As you can see for class 1, you see a pretty open airway, and you can see that teardrop, you can see that uvula, you can see what's behind. And as you go into class 2, you see it starts to get a little 30% less. Class 3, I think I see about 15%. Class 4, I don't see anything back there, which is pretty indicative of an obstruction in their airway. If a person is just actively sitting there and you can barely see their airway, they're probably a higher candidate for sleep apnea. And so these type of things can be observed, and it's a very unique capability for you to be able to see that, because as I mentioned, people aren't going to be walking around opening their mouths to other people. And unless they're seeing a physician before, if they're getting pre-screened for a sleep study and the physician asks them to do that, it's very uncommon that they're going to do that. So this is a very cool opportunity to be able to reach a group of people that otherwise would have had no idea what's going on. So sleep testing and screening, it diversifies the dental practice. I mean, it allows you to be able to see and have conversations that are different than just the general operations of a dentist. I myself am not the biggest fan of the dentist from my own previous experience, but I do go. And I recall at times my dentist would start talking to me about sleep apnea and mentioning these things, which was really cool, because I was like, let me tell you what I do. And it created this like rapport and this engagement that made me actually feel a lot more calm, a lot more relaxed. And I found that it made me more consistent. And that was just upon conversation of what I do and what sleep apnea is and all of those things. So for a patient, this can definitely help them be put on the proper road to healing with a diagnosis. It offers a financial opportunity for, if you're offering oral appliance therapy, it gives them an opportunity to, for one, identify what's going on with them outside of their general dental, procedures. It's liberating in that way, because it also incentivizes them to finish restorative work, prosthetics, other things that they would have otherwise put off. It'll keep them consistent. It's a motivating force to help them finish work that they might have not done before. So I think it's really cool. It's kind of like a full circle. It has this like philanthropical type of, altruistic energy that I think a lot of patients would appreciate, and it would work in full circle. And I'm going to go ahead and hand it off to you, Lacey.
Yeah, I'll add to that. I think it'd be hard to find somebody who doesn't want to sleep better, feel better, when they wake up, feel more rested, look better, lose weight, see all those benefits. But the kicker is you can't fix something if you don't know what's wrong. So screening is such an important place in this process. Okay, so sleep testing. I've always loved this little picture because there's so much anxiety around testing. What's going on with my sleep? This is what people picture when they think about an in-lab sleep study. Like, I had real conversations with patients when they would come in and they would point at the mirror on the wall and ask me if I was on the other side of that little circular mirror. And I'm like, no, it's not that creepy. I know this is weird, but it's not that creepy. So it is a very normal thing to have this anxiousness around sleep testing. In-lab studies have their place, but I love and I'm so grateful for what home sleep apnea tests are bringing to not just the market, but like bringing to us as clinicians and to people who suffer from sleep apnea and just sleep disorders in general. So it's not always that scary. All right, home sleep apnea testing. So this is just a visual of one that I actually personally worked with a lot. They've come a long way, and I've got a couple other I'll show too, but this is just an Alice Night 1, where it just, instead of the previous picture where all the wires were everywhere, you're looking at just one belt monitoring respiratory and body position. You have a nasal cannula where they're able to monitor just breath, and then you've got pulse ox where heart rate or pulse rate, and then you also know blood oxygen levels. It also picks up a snore vibratory index as well. So you get a really good just summary of what's going on with that person's sleep, even with minimal wires. And I think you'd have a lot better buy-in with somebody bringing home like a little case or something smaller, instead of having to schedule and wait for an in-lab sleep study. So the significance of home sleep testing, it originally was called HSTs for years and years and years, and the AASM put this A in there to really differentiate. This is a home sleep apnea test where we are focusing on apnea. It's like a sleep apnea screener, because there are a lot of other sleep disorders that really can't be seen with the home sleep test. So if you're looking at sleep apnea, this is a really great resource. So there are lots of different types. This is just a handful, just a quick picture. You've got the watch pat, where it's literally a watch instead of having the belts and everything. It's got everything on your hand. There are some that are just rings, like the sleep image. But yeah, there's a variety. And again, that's really cool because I like options. But it allows patients to sleep in their own home, in their own bed, if they need 2 nights sleeping with it to get a good outcome. It's not just like they're going into the lab and they may or may not sleep. So less cumbersome, a lot easily scheduled, and definitely gives you the severity range, mild, moderate, severe, gives you really good insight and quick turnaround time too. So with in-lab polysomnogram, nocturnal polysomnogram, NPSG is what we would always call them. there are a lot more wires. You're monitoring everything from EEG, brain waves, to heart activity, leg movements, a few things in between, sometimes arm movements. So this is just this more just thorough summary of this person's sleep. So say somebody struggles with seizures and that's part of their sleep problem. This is something that's going to be really important to have EEG in there to monitor. Somebody's struggling with restless legs or periodic limb movement. Sometimes that's a really big issue if they don't have sleep apnea, but their sleep is really disturbed. That's something that you can pay attention to with the in-lab sleep study. If somebody isn't keeping wires on in their home sleep study, the cool thing about having the in-lab PSG is you have a human being, a sleep tech, somebody who's skilled and just there. They're the ones putting the wires on, educating as they go. They're there if something falls off. They're there for issues like you need to monitor for heart problems, issues in the EKG, more in depth, more detailed. So some of the biggest differences you'll see in the home sleep testing versus PSG. Again, the PSG is required this lab presence. You have somebody there to walk through that patient with. So if you have patients who need a little TLC, specifically people who have COPD or congestive heart failure, neuromuscular disorders, children, there's a time and a place for this in-lab sleep study where you maybe need a little bit more thorough. Or say you've done home sleep studies and you're not getting the results that you need, it's not accurate and you're not getting good data, you can keep that in mind. If you see crazy readings on the pulse ox with the home sleep study, there could be some weird AFib or there could be some VTAC happening that you may not see with the actual visual. And I'll move forward with this next page too, with this actual visual of the ECG or EKG. So again, I'm touching on what Sean's already mentioned with the side-by-side home sleep apnea testing versus in-lab. Again, there's a time and a place. People who need a little bit more TLC. I'm a huge fan of the in-lab studies because that's where I started, and I think they're important. But with our diagnosis dilemma that we mentioned earlier, that 80% of people and probably more who have not had any diagnosis, I love that our home sleep studies give us this quality reading, and it's enough for us to see, oh wow, yeah, your sleep's really disrupted and you're not breathing very well. Like, we could move forward with treating you without having to put them on a waiting list to get in the lab for a sleep study or going through this long drawn out process. It's something that they're sitting in your dental chair and you're working with them that day. You're able to say, oh yeah, like, you've got enough going on in your life that it's worth, let's test, let's figure it out. You can get some results like this week. And like, I think that's just a huge sigh of relief, and that conquers a huge problem. So again, I'm a fan. Y'all are so uniquely positioned to help people who need a lot of help.
Thank you, Lacey. I could listen to Lacey talk all day. So, so let's talk a little bit about the accuracy of sleep testing. So sleep tests are reviewed by a board-certified sleep physician. They are trained, they are qualified to be able to look at these studies, as well as the studies are conducted by night technologists that are trained, RPSGTs experienced, and reviewed and scored by equally qualified sleep technologists. And by scoring, I mean they have to go through every single one of these pages. They have to mark the stages of sleep. They have to mark any arousals, anything respiratory, desaturations. They have to go ahead and go through every single page and go through sometimes 800 to 1,000 epic, which is 30-second periods for a study. So it's a lot of work, but they are qualified and they do a fantastic job. In that vein, emerging AI is allowing for high quality scoring with a high level of agreement. And I'll touch on that in just the next slide. After this follow-up testing and verification from the technologists after they've reviewed a study that's been scored by AI is done to be able to make sure that everything is done effectively, properly, everything is good, and basically have their seal of approval. So, rising role of AI in sleep interpretation. Artificial intelligence, our favorite topic this year and in the future. I'm going to go ahead and read a quick quote by Peter Diamandis. AI will be the single greatest contributor to our longevity. It'll drive the breakthroughs. The amount of data we're gathering from all the experiments and research, the human brain cannot fathom it. AI is the only tool we have to do that. So the last two sentences I want you to kind of think about, very important. So the emergence of AI in healthcare. Historically, sleep studies have been scored manually, as I mentioned. It can be tedious, especially if you're a daytime scorer, you're scoring 8 to 10 studies in a day. That's a lot of clicking. And especially if your patient is very severe, they're having, multiple sequential, consistent apnea throughout the entire night. It could be a pretty, stressful type of job. And it also is it causes a lot of fatigue. I scored for a lot of years, and it definitely went to my head, no pun intended. So how much has it advanced? I think Michael mentioned in the beginning about banana paper. Way back when, maybe not way back when, the studies used to be generated on paper, and they had to review them on these huge GRASS machines that were humongous. And that's how they had to score and review studies. And I can only imagine that took hours. Technology advanced, and then at that point, it became digital. So you're able to score those studies digitally. And now we're entering this world of artificial intelligence, which is furthering the technological divide. Before I mention that, there's something called inter-score reliability, and that's the agreement that technologists throughout the world, the United States, all the RPSGTs, their agreement on stages, on respiratory, on everything all inclusively is about 85%. There's still about 15% variability. So even if I was to score a record that I had done a week before, it's very possible that I'm going to score it a little differently. That variability just exists because the rules for staging, sometimes they can go one way or the other. There's a lot of different elements. Cue to the introduction to AI. Artificial intelligence has allowed the ability to have a large repository of information, data sets with millions of studies, to be able to have a deep learning model and understanding how and why certain decisions were made in scoring, to be able to come up with the closest representation in making it easier for these technologists. So instead of spending an hour and a half on a record, a lot of that study will already be scored. It'll already be staged. It'll already be marked for them to simply go over and review. All you'd have to do is just kind of go over the study page by page and kind of confirm that you agree with what's going on, which in turn would allow you to spend a lot less time on scoring that study, which essentially can prevent your brain drain from happening, your fatigue, as well as giving you opportunities to do other things that a sleep technologist might feel more inclined to do, such as working with patients in other procedures and education, a lot of other things, sleep coaching, adherence, compliance. So there's some other elements to the potential future of sleep in healthcare. So there's screening patients that otherwise wouldn't have been able to be detected. There's predictive algorithms that can be used to detect potential outcomes, endotyping and phenotyping, being able to see the compliance of a patient, to see their CPAP data, to see how much and how many nights have they been consistently wearing their mask. Because one of the biggest issues that we have with people who are wearing CPAP is adherence and compliance. They typically will wear it and then they won't. They might have had a night where they were put on the CPAP. They didn't have a lot of education. They kind of freaked out. They know that they have to wear it, but they wore it the first night. Maybe they didn't put it on right. They're terrified of it. They feel terrible. They feel like they can't breathe. A lot of things that could have been alleviated if they had the proper time and TLC and handholding with the technologist or another technologist during another time. So these predictive algorithms can be able to figure out the pattern in which constitutes a higher or a lower risk person who might end up not wearing their mask or might end up being non-compliant. And we can go ahead and identify these people and being able to help them and identify exactly what is causing them that problem so that they can remain consistent, compliant, and extend their life essentially. And as I mentioned, the allowance of medical professionals to spend more time with their patients, instead of having to score records all day long, you can spend half that time scoring them. You can go ahead and have mask fits with them. You can do something called a PAP nap, where, you know, a patient who's having a really hard time adhering to the mask is able to spend a couple of hours, sleep with a mask. You're able to observe them. You're able to see exactly what's going on and help them to remain consistent. And as mentioned in the last two sentences of that quote, AI does not have fatigue. AI does not get tired. We get tired. I've pulled 19-hour shifts, 18-hour shifts, 2-day shifts. I've done it all. And I used to think that I was the king of the world. And I realized my own mortality, that I am only human. But AI is not. It is consistent. It has no fatigue. It can fill in where we cannot. And one of the last things I wanted to mention is that sleep is one of the most important parts of our lives, but we're human. AI introduces a blessing in which it is able to carry the burden and weight that we just cannot do. It does not feel fatigue, it remains consistent, and it does not need sleep. Thank you.
Boom. Why do I feel like you just dropped me? Man, you guys, thank you for dropping a lot of information here. Sean, seriously, AI doesn't have apnea. That was the one you missed.
I know. I thought it was a little bit too on the nose.
Yeah, it doesn't snore. I mean,
I'm gonna use that next time.
Maybe that's just for audiences like me, but hey, there's probably one. I know there's at least one or two people on this webinar that have the same sense of humor. So this is great, man. You got there we go. There's the workflow slide. So this is actually from one of the case studies that you guys did on us as a vendor partner. So basically, everybody, this is my one slide. This is where I get to talk. What we've done on the Awaken to Sleep Enzo Data collaboration is our goal as a company is to leverage the tools that these folks have created to integrate that into the HST workflow. I still say HSTs because I'm old. Sorry, Lacey. It's fine. We all know it's only for sleep apnea.
Do it too.
But this is really the goal is to have access to care, what she mentioned earlier. In a perfect world, every patient says yes to everything you recommend when you recommend it. They have immediate access to care, and we can get all the data that we want from the in-lab PSG. In reality, that doesn't happen. So when we don't have access to that, we use HSATs. We hand them out to patients from the office in every state that we're allowed to, whether it's a titration test or diagnostic efficacy, whatever you guys are doing. We want to bake into that workflow this integrative process. So in simple form, basically the patient gets prescribed the HST, it gets handed out, they wear it, that device data comes back through our portal, gets ran through this AI process before the report and the data is ever read by a physician. That gets read by a physician and interpreted if it's a diagnostic or efficacy. If it's not, and it's just a titration in between when you're checking yourself, that's just going to be read by the AI and scored as such. And then it comes back with data that's scrubbed. So there's two different arms or mechanisms that you all can pull with that. Any diagnostic or efficacy test that's uploaded is automatically sent to a sleep physician that's licensed in your state so that they can render either a diagnosis or show that the therapy that you've delivered is efficacious. So that's the process. That was a whole mouthful. We do have a bunch of questions, and I'm going to say, let me show you guys the next slide. Let me see if this actually works. We did a three-way it works. Oh, we lost Lacey's video. I clicked the button and she's gone. So you guys know that we usually try to do something with a coupon code for you at the end of these webinars. We got a clinical course coming up. If you want to hang out with a guy who has way more experience than ego, Dr. Justin Elikofer has delivered thousands of appliances to lots of people. He gets in the weeds on the clinical protocol. When do you hand out tests for titrations? What appliances are you using? When? How to deal with contraindications and issues that patients have, all that stuff. If you guys want more clinical info, you can go there. We also have, I'll pull up in a minute, the link to get to a free coaching call, which you guys know we do. That's on the website. We're happy to help however we can. But if you're looking for clinical insights, hang out with that guy. It's 7CE's virtual on Friday, the 27th of October. That is a few days before Halloween, so you don't have any excuse. But all right, let's get into the questions. There are several. One thing, Sean, that I just have to say. I know you worked at Stanford, and I know there's this rivalry with Harvard, but Dr. Patty was the anesthesiologist from Harvard, and that's where we get his thing. So, we got to give credit where it's due.
There we go.
We are the best coast, and they're the beast coast. If anybody has opinions on that, you can put it in the chat. It's totally fine. But yeah. All right. So on to the questions. Tony, of course, as always, do we have access to the slide? Yes, Tony, but you're going to get them in PDF, and there's a video after this. You know where they go, on our website and in Sleep Care Network for CEs later if you want to watch it pre-recorded. All right. Jessica had a question. Is it more accurate to do a hospital setting test or a home sleep test? Lacey addressed that. More accurate is really not the question. It's what data are we getting? How many channels? On the home sleep test, we've got to have the proper amount of information, and we have to run it through an AI algorithm to get the accuracy. That was the main take home from tonight, y'all. Come on now. Lacey, I'm going to ask you to answer that, though. From your setting as a sleep tech, you've seen this a lot, and you see the AI. When should someone use, refer out for a PSG if they've done an HST and they feel like it's insufficient data? Or if it comes back through your algorithm and it says, oh, we don't have enough good data, even though the recording looks long enough, at what point do they do another HST versus a PSG?
I would say a few really big red flags with one. I'm sure y'all have some type of intake form and get their medical history, but for people who have any kind of like COPD, any kind of congestive heart failure, any kind of neuromuscular disorder, like those people really need that in-depth TLC. They need those extra wires. And there are people who have hypoxemia issues, and they may need oxygen during their sleep study to figure out what's going on. There are a variety of things. If you see strange things popping up in the pulse rate, and if you see, it's looking like you're seeing some tachycardia and it's a little bit all over the place, you may see really low oxygen levels. There may just need to be a little bit more TLC, a little bit looking into that. Or if you're just not getting, I think there's one person I tried to do home sleep studies on, and her sleep hygiene was terrible. Like she would literally set alarms on her phone to wake her up so that she could watch certain shows throughout the night. So like there are some people who just need to be in a setting that's centered for sleep.
They need better habits. That's a poor life choice for anyone who's questioning that. Yeah. Do not wake yourself up to watch a show. It is a bad choice.
No.
Bad choice. Okay. If it is not expressly specified in the sleep, okay, can I assume scoring of AHI 3 or 4%? So the 3 or 4% criteria that you all have, we know on the inside this is a toggle between. AI now scores both simultaneously, so we just pick which output. On the report, does it show which percent criteria was used every time on every report? Sean.
Can you clarify that? So are you saying that on the report, is it showing 3% and 4%?
No, the question was so in our service, they upload through our portal that automatically gets sent to Enzo. So that's a covered service that we offer for every interp. So when it goes to you guys, the end output is the report that comes through Enzo Data's process. On that report, does it show the scoring criteria that was used, if it was 3% or 4%?
I believe so. Yes. If it's already been toggled, yes, it should have that information.
Yeah. Cool.
We've also just had an update where it does include both on the reports. which is really beneficial. But I believe the home sleep studies mainly focus on the 4%.
Yeah. And that's a payer guideline. I know the AASM has gone back and forth over the years
love it.
between the two. Gotta love that consistency. No comments necessary. That was a free read.
Comment necessary. Look, you made me come on camera. I wasn't supposed to do that. For Awaken to Sleep folks, they dictate what percentage they want based on their workflow and whether or not they're working with insurance. So because of our capabilities with Enzo data, we can choose to score it at 3 or 4%. So dentist, based on your workflow, you tell us 3 or 4%, since you're the one who's holding the medical records. So there you go. Sorry. Thank you. Bye.
Knew I was going to get in trouble at some point tonight. Thank you, Chad, for your contribution. We appreciate you. Truly. Okay, so this is another one. What do you think of the Ring and the Night Owl? Let's call that anything in the PPG world. Go ahead, y'all. Everybody's got an opinion. You're allowed to have your... Sean, I see you guarding your opinion. You're a sleep tech who likes a lot of channels. Go for it.
I am open and I'm optimistic of the technology that's emerging with PPG in identifying sleep. And, I have an Aura Ring. I've tried different things. I am openly optimistic to it. I am I'm still a little old school. I'm not going to lie. I'm still a type 3 type of guy. And that's just kind of how I've been, but I understand its importance and how globally and internationally this market can reach out to people who otherwise would not be able to go and get a device and do all of that. So I'm pretty optimistic.
Lacey, anything to add?
I tend to agree. I'm very optimistic. Again, for the people who otherwise would never have a sleep study, if that is their option and that's going to get them in the door to give them answers, yes, like I'm all for the screening and to give them answers on what's going on. Because the main thing is it's going to give an AHI, whether it's mild or severe, and then it's going to give oxygen, that breathing, like what their oxygen levels were doing. And so I work with a lot of patients who their doctors used WatchPad specifically, and I'm able to go over those two main things and explain to them, like, this is what we got, and this is how it affects your body, and this is how it affects what you're experiencing. So it gives me what I need for the conversation, but at the same time, I love all the details too. So I'm very open to the advancements though.
As sleep techs, we're weirdos. I mean, let's just own it. Like, all of the squiggly lines look way better to us than a few channels, but everybody else looks at that and goes, oh, that makes much more sense. I mean, I'll weigh in, guys, on the dental side and holistically in treating patients with airway issues. Ultimately, it's going to come down to access to care and your workflow, knowing your workflow. Night owls currently are on a moratorium for ordering. You can't order them for another 3 or 4 months. And they're single patient use, which means there's an increased cost per patient. If you can incur that in your plan, then do it, if that fits your model. If it doesn't fit your model and you have access to a type 3, like what Sean was saying, like the Alice Night ones that you guys, if you've been on our courses, you've seen those. Those are longstanding, tried and true, and they have the respiratory inductive plethysmography belts and all the bells and whistles. Like, yeah, cool. If you have access to that, you can run that test for $6 plus the titration review through AI. I mean, that's a very cost-effective test. So ultimately, it comes down to access to care in your workflow. All these things have to be cleared by the FDA, FYI, since we still need acronyms. So ultimately, our opinions are just that. But I appreciate you guys being holistic in those opinions too. Any connection between sleep apnea and sleepwalking? I just like hard right. Who wants to take that one?
I think from what I've researched and what I've looked at, I mean, there still isn't so much of an identification for what is the root cause of sleepwalking. I know it's common amongst adolescents. It can go into adulthood. There can be a correlation, but I don't think it's not one of the number one things that we're looking for. If you're sleepwalking, you might have sleep apnea, but it is possible. However, I don't think there's a huge correlation, but I could be wrong.
I think you're right. I've not read of one. But two things can be co-present in a single person and primary, not
think it'd be
secondary.
I think it'd be
right?
awkward walking and then just having apnea as you're walking and not waking up.
Well, you're elevated.
That's
So
that's sleep tech humor, man. Like they have apnea first, it wakes them up and then they walk, but they can't have apnea when they walk. That's just, if you have a video of that, I want it, to be clear.
Oh, I've been looking for it next to the one patient levitating.
So so this is a cost question. So I'll go ahead and take this one just because it is our service that you guys are utilizing through this. So one is there an extra cost to this? The answer is no. We made the decision almost 2 years ago to start working with Enzo Data within our interp service fee and our titration service fee. This is automatically included in every single test. So no, you don't have a choice to turn off the AI that is behind the scenes doing all of this good work. You don't, because we pay for it. We want good data. If our physicians are going to read it or you're going to talk to a patient about it, we want you to have the right data. So it's automatically included, no extra cost. Why the pineapple? Why is the pineapple in your logo?
Oh, there's so many different interpretations. I mean, besides the fact that pineapples are delicious, I mean, they're resilient, strong outside with a sweet, core inside. It's great for your nutritional. I mean, it's awesome. It's cool. It's ironically one of the reasons I applied to work at Enzo. I saw the pineapple and I was like, this is a company that understands care, but also understands like just the human element, the personability. It's kind of like, it's ambiguous, I mean, it's not easily attained. You might have to walk up the mountain to kind of find that one tree to get that pineapple. I don't know. There's so many different, it's abstract. Whatever you take out of it, if it brings you joy, it brings me joy.
I'll add a little something. I actually asked this question in my interview. I don't know if this is appropriate to say, but I'm going to say it because it was like maybe a year prior. My father-in-law said something about pineapples being a symbol of swingers, and I had no idea. I'd never heard of it. And so I was like, what does the pineapple mean? And I actually mentioned that in my interview, and my precious interviewer was just like, one, I think that's an upside down pineapple, and we just like to make sure all of our pineapples are right side up. But in all like seriousness, I think that the meaning behind it is hospitality, and just being hospitable and making a difference and helping solve issues in this sleep world, like that brings us joy, but also it's like this fresh splash of goodness in our realm. So we'll laugh for the night.
I mean,
and who doesn't love a pineapple?
I don't work at your company, but my thoughts are very simple. It goes good on pizza. Argue with me. I'm just kidding.
Ooh.
A lot of people would argue with that. It's it's a lot of fun. And you guys are doing great work in the patient care sector, for which we thank you in addition to the time tonight. We got one more thing. Everybody, I want to say thank you for joining us. You're going to have a CE link in the chat when you leave Zoom and in your email tomorrow. Brian Shever called me a pizza communist. Thank you, Brian. We appreciate you too. We'll argue later. Guys, truly, I thank you for your time. This is late your time, Lacey. And Sean, we're just, even Steven over here on the best coast.
Just hanging out.
Any parting words for the audience from your perspective to theirs?
For me, I would just say the number one, just like Lacey mentioned, hospitality, awareness, understanding that, like, why are we here? What are we trying to do? We're trying to help people sleep better. I mean, all in all, it's so simple, yet it's so complex. It's pretty much everything. So just continue to have your impact, continue to keep imparting that knowledge. That's the best thing that we can do, is share this knowledge with one another, and hope that we look back 10 years and we'll be like, you know what, we contributed to this, and we all can. And Lacey.
This is just on a light note. If you help people sleep better and get them feeling better, they may be able to smile more and show your lovely work as dentists because they're happier. No, really, thank y'all for your time. It's been a joy.
Thank
I
you.
love it. Appreciate you guys, friends, and soon to be friends on this audience. We appreciate you all. Thank you for your time tonight. We do value it, and keep doing the good work that you're doing. We're here to support you as we can. Thanks so much, guys. Have a great night.
Thank you.